second webinar on the same topic. So it's my pleasure to welcome our two speakers for tonight. First, Dr. Kandanearachchi. Priyanta is no stranger to us. He's a consultant obstetrician and gynecologist, Amarasena University Health Board, West Wales, and he's accredited colposcopist in UK. And he had conducted several workshops here. I think last time we had one in CI Maharagama. Some of you must have attended. And he's a training in colposcopy, and he's a training in obstetric emergency program. And in addition, he's a accredited trainee in intrapartum fetal monitoring in UK. So I warmly welcome Priyanta for this webinar. And our second speaker tonight is Dr. Asela, Amarasena. And Buddhika recently came from UK, and he's right now working in base hospital in Kandanearachchi. He's a consultant in Kandanearachchi right now, and he obtained MRC in 2022, and he has a lot of experience in physiology of CTG. So today's topic is on recognizing hypoxia in fetal medicine. So please free to write your questions and comments in the Q&A box, so we'll be able to take some questions at the end of the session. It will be a long session, almost like a 1 hour. So we should have some time to discuss some of the questions. Right, Priyanta, it's over to you.
Thank you very much, Mangala. Thank you everyone for joining today. Can we see the slides? Can you see the slides?
Yet.
No. You can see the slides.
No.
No. So
You need to again share.
Okay, I'll share it again. You can see.
yeah, we can see. We
You
can see now.
Oh,
Yeah.
excellent, excellent. Thank you. Thank you for joining today. Thank you for giving me this opportunity, and I'm thanking SLCOG, and thanks for joining Asela. We are trying to share some of our experience we gained doing this CTG training in my hospital especially. So we'll see how it's going to be useful for all of you, and we can have a discussion at the end. Please feel free to raise any questions, any doubts you have. Right, okay. Little bit about what I'm doing. We are one of the first hospitals in Wales to transform into physiological interpretation of CTG. I work at Hywel Health Board, West Wales. So I got into this physiology, I think about 3-4 years now. And I'm involved with organizing CTG training reflections every weekly, and lots of CTG seminars we have organized. Currently, recently, entire Wales have changed to physiological interpretation. We have new organization called Intrapartum Fetal Monitoring. It's called IFS, Intrapartum Fetal Surveillance Wales. It's a new group, new organization. So we take part in that, and I'm involved with them as a trainer. So I thought I should share a little bit of my experience with you. Asela was with us for 2 years, so he's joining me today. So he was involved with this CTG interpretation as well. So please raise your concerns, so we'll have a good dialogue as we go on. Right, little bit of background to this physiological interpretation. Some of you may have heard about this each baby count reports. Now, this is something came up in England. England had this each baby count reports, and these surveillances were done to see what happens to the poor outcomes of the babies. You know, babies who develop hypoxic ischemic encephalopathy stages more than 2-3, and the babies who have lost their lives. So periodically they were reviewing these cases, and they they have seen a common trend. They have taken lots of measures to improve this outcome, but over the period of years, they have seen the same trend. There were lots of reasons, not only CTG, communication, training, they have highlighted lots of reasons, but big chunk is about CTG training. And big proportion is highlighted as misinterpretation of CTGs responsible for the poor outcome, which could have been corrected with the right interpretation. But it did not improve with whatever the measure. So in this backdrop, this physiological interpretation came into clinical practice, and it was pioneered at St. George's Hospital. You all must be knowing Edwin Chandraharan. He's one of our own Sri Lankan, and he pioneered this physiological interpretation. St. George's Hospital initially showed very dramatic results, how it improved the outcome of neonates when CTG interpretation changed from following pattern recognition to physiology. I will explain that what it means. So master classes were conducted right throughout UK and even outside UK. And I think 2015 in our hospital, the first green box you can see in this one, Glangvili General Hospital, Havalda Health Board. 2015, after a master class, our lay board lead, again another Sri Lankan, Mr. Shankar, decided to change to physiology because we were struggling with battling this HI 2 and 3, and it was not improving. So after seeing these statistics and improvements, he has decided, and we are doing really well at the moment. I'll show you later on what we have changed. Not only us, there's a list of hospitals. All of them have shown improvement in their neonatal care. So it has, the tide is changing now. Entire Wales has changed. I think we have reached the no return point when it comes to physiology now. As we go on, I'll explain the changes took place. In Wales, 2 hospitals started, Glangvili and the Newport Grange University Hospital. So slowly, other hospitals are joining us now. This is what we have achieved. 2015, we changed to physiology. Since 2015 up to now, not a single fetal blood sampling has taken place. And look at what we have achieved. Our HI rate is coming down, and we have organized our training by formation of a CTG teaching group. And ever since then, this slide is showing what change it took place, but actually the change is visible even from 2015 time, as you look at it. And we are getting better and better. This statistics is only up to 2023. And we achieved it without increasing the emergency cesarean section rate. Initially, there were some anxieties. Okay, what will happen to our cesarean section rate? Will it go up? Then it will be a bit of a cause for concern. But when we analyzed, actually, the emergency cesarean section rate has gradually come down, which is amazing. Because we don't do unnecessary emergency cesarean sections now. We always think what is happening with the baby. Is the baby okay? And we don't kind of jump to do a cesarean section by looking at decelerations now. Our thinking pattern has completely changed. And it is lots of hard work, lots of teaching, because, in a hospital, staff members are not static. Doctors, midwives, they come and go. Some trainees come, they finish the training and go. New midwives join, new doctors join. So it's a constant battle. But we were very hard on it, and we constantly pushed and trained our staff on regular basis. And it can be done. It can be done. We proved it can be done. So now our entire hospital speaks about physiology. So we are following physiological guidance. It is much easier now because as entire Wales is changing into physiological interpretation, the life is a lot more easier now compared to previously when all different hospitals were following different guidelines. Some were following NICE, some were following FIGO, some were following physiology. Now we are all following physiology. Life is a lot easier now. Now that was our hospital. Now This is some other hospitals in UK plus outside UK. So the hospitals which followed physiological interpretation, we have seen these improvements. The first blue bar is about reduction of fetal. Is anyone asking a question or something? No, ne?
No, not.
Right, first bar, the blue bar is reduction of, it is somebody's talking. Anybody's asking a question or something now? No.
No,
Okay.
no. Yes.
Right, the first blue bar is fetal blood sampling. I mean, you can see 100% reduction of fetal blood sampling. None of the hospitals have done fetal blood sampling since the introduction of physiology. I think there will be many of us in this group, in this forum, who have done fetal blood sampling when they're in their overseas training, and I have done it so many times. I feel extremely sorry for these babies because it's completely a futile exercise because it doesn't mean anything. Now fetal blood sampling is eliminated even from NICE guidance. It's gone out of the window. Nobody does fetal blood sampling now, but it got eliminated when the physiological interpretation got more and more used widely. So place of fetal blood sampling got completely, it has no place now. So the second bar is yellow bar. What does that mean? That means reduction of emergency cesarean section rates. What's a percentage reduction? Variable achievements, but none of them have increased their cesarean section. So it's a common trend in all the places who have started physiology. And reduction of HI is the light blue bar. So you can see so many hospitals have achieved a significant reduction. So this evidence is compelling. If somebody has doubt, okay, whether it works, the evidence is all over the place. I mean, we have lots of publications, lots of articles published from different sources, different hospitals from different countries. When you follow physiology compared to other guidance, the evidence is very, very compelling and it's visible in all the hospitals. So what's the difference between pattern recognition and physiology? This is a question many people ask. So pattern recognition is, you give a particular pattern, like for an instance, fetal heart rate is between 110 and 160 is normal. We still consider that as normal. And we believe if, that's been removed from even NICE guidance now since 2022, but we had a box in NICE guidance. If CTG in half an hour shows 50% of the half an hour strip shows variable or late decelerations, that's a pathological CTG. So it's a particular pattern. We are recognizing a pattern, but we don't understand why that pattern is important. So in a kind of a way, it's a kind of blindly following a particular pattern and taking action. If I remember that guideline, if you see a pathological CTG, you do fetal blood sampling. If it is normal, repeat that in half an hour if the same pattern continues. So there was no scientific basics as such for that pattern. Apparently, it is not evidence-based. It is based on few people's expert opinions. There's no scientific basis for that. And the interesting thing is, when you do a cesarean section based on that particular pattern, the babies come out screaming and crying. I have experienced that many times. And, figures quote from research articles, 90% of the babies come screaming. Your chance of finding a good, healthy baby is 90% if you do a cesarean section for pathological CTG. So something not right in that. So that's why this change of thinking has taken up by many places, because now we are, rather than looking at a CTG and following a particular pattern, we are diverting our attention to trying to understand what is exactly happening with the baby, rather than trying to recognize a pattern and act. We are trying to think, analyze what is actually happening with the baby, and we act accordingly. That's the difference. So we are not following any more patterns. We still have guidance, but we are not following a particular pattern or particular box and act. What we do is we try to understand what is happening with this particular baby, the baby in front of me, when we are looking after the baby. So that's the beauty of that. And during our training and teaching, we try to interpret the CTG changes, and we can correlate that with the outcome. So that's a big learning. As we do that repeatedly, our thinking, our learning is also improving. So that's the way to improve this. It takes a long time. It took about 2-3 years to get some understanding about this, because it's all new to all of us. Now we have done lots of hard work. Most of our staff members, doctors, midwives, they all speak the same language. So when I say gradually evolving hypoxia, midwives recognize that. So it's a lot easier once that basis is laid in the working place. I'm sure we can do that. I think we can incorporate this into our system. We'll see how it is going to be incorporated as we go on. Right. When it comes to physiology, or when it comes to fetal well-being or fetal monitoring, the biggest part is uteroplacental unit. Sorry, the placenta and the umbilicus cord. If you say uteroplacental unit, it's fine. It's basically the lifeline for the baby. This is the lung for the baby. Now, this is a static unit. You cannot control much of the activity of this placenta and umbilical cord. What is changing its circulation, all these things is totally depend on the perfusion coming from the uterus, uterine contractility, all these things outside factors. But when it comes to placenta and umbilical cord, it's kind of a static unit. What is happening in this unit? And you can see cotyledons providing, arterioles providing oxygen to the intervillar space, and the baby shows baby's umbilical cord throws this villi into the intervillar space. So oxygenation takes place in this area, and the excessive carbon dioxide will be transferred back to mother. So this is the normal placenta. But this placenta is not same for every baby. That is the key thing. That is the difficulty of following one particular guideline. Like, now the key thing is, now you can't, it's difficult to say all the term babies' fetal heart is between 110 and 160, and any baby whose heartbeat is between 110 and 160 is normal. It is difficult, because I will come to that when we discuss about baseline, but think about this placenta. So what will happen if there's a placental compromise? In a growth-restricted baby, the placental villi will be smaller, poorly developed, intervillar space is less, circulation is less. Sometimes placenta can be calcified, so the oxygenation doesn't take properly. What will happen in chorioamnionitis? Placenta gets swollen, metabolism is faster, oxygen transfer is faster, oxygen consumption is faster, and again, because of the swelling, intervillar space, circulation will be less. Same will happen with diabetic mothers, and their placental villi are larger because they are big babies, and as a result, those babies can get hypoxic faster. So unless you understand that physiology, when that kind of a baby is in labor, if you try to interpret that CTG the same way as a normal baby, it's a bit difficult, because we know these babies are more prone for hypoxic challenge. Then we have to think about the umbilical cord. And the umbilical cord is usually well protected with Wharton jelly, and it's slippery moving around. But if the baby is growth restricted, that jelly is less. So very easily that cord can get compressed. So that's why the those babies can get decelerations easily. We'll come to that later. Just think about this unit. This is very important when we are trying to interpret physiology. So this is the fetoplacental unit actually. This is relatively a static thing. So what is variable is what is happening outside the baby. The baby's heart is the only thing we can monitor. May it be intermittent auscultation, may it be continuous fetal monitoring with CTG, whatever it is, that's the one going to tell us how the baby is. So whatever the change happens within the baby, we have to rely on the heart rate, rhythm, and the various patterns. If you think about the heart rate, what controls it? Because babies facing lots of challenges, especially in labor. Not only in labor, even antenatal periods. But if you think about labor is a very stressful journey. So baby can get pressure differences, baby can get hypoxic, babies can develop chorioamnionitis. So heart will change according to these various situations. How does it happen? Now we think about a situation, if there's a cord compression, if the cord is completely compressed, that will increase the pressure of the baby because the umbilical arteries can't pump. So as a result, baby will sense it. There is this wonderful receptors called baroreceptors to protect the myocardium because high pressure can damage the myocardium if you try to pump at the same rate. So it immediately reduces the heart rate. So it's sensing the pressure changes. At the same time, if this hypoxic stress continues, now pressure changes and baroreceptor related decelerations will not cause hypoxia initially, but if for some reason something happens repetitively, if hypoxia gradually develops into the system, the next system to come into play is the catecholamine system, from adrenals. So that will push the heart rate up. Still, baby could be compensating. But if hypoxia is developing gradually, and when baby is unable to tolerate this hypoxic insult and the metabolic acidosis is developing in the system, hypoxia is developing into system, then another type of receptors coming into play. That's called chemoreceptors. We will discuss this further. This is just an outline. So remember these different components: baby's heart, catecholamines, baroreceptors play a part, chemoreceptors. The other important aspect is the autonomic nervous system. And we have central nervous system, autonomic nervous system. Autonomic nervous system plays an important part in controlling the fetal heart. It can throw the fetal heart rate high and push the fetal heart rate low. And that's maintaining the variability in healthy status. But autonomic nervous system also can be affected by hypoxia, chorioamnionitis, whatever it is. There are so many drugs. So all these actors play together, and ultimately it will be manifested by fetal heart. So what we are doing is we are monitoring the heart and trying to understand what is happening at the different levels. That is physiology, bearing in mind what is happening at the fetoplacental unit as well. Is it all clear? And any questions? Anybody want to raise? Happy for me to continue?
Yeah, better.
Okay, one more aspect, metabolism. We can't forget that. If baby metabolize aerobically, then 38 ATP is normal aerobic metabolism. But if baby metabolize anaerobically, it will be production of lactic acid and less ATP. So we all know that. Just to little mention, if at all anaerobic metabolism takes place, all I want to highlight is there will be accumulation of lactic acid, which is very important in physiological interpretation because when it comes to that stage, we know that something is not right. When we come across clinical situations, now we all manage babies in labor. We are all comfortable. We are all competent in doing that. Now, the thinking is moving. We said that we are moving away from pattern recognition to physiological interpretation. So how can we have a systematic approach to interpret this CTG? So that is the challenge. So we are not following the pattern, but we are trying to understand what is happening to the baby. So when it comes to hypoxia, there are different types of hypoxia we have to think about. We are always looking for these kind of changes. What kind of change happening with the baby and how can we detect what type of hypoxia baby is going through if it is hypoxia? And then there is another group called non-hypoxic changes. The biggest culprit is chorioamnionitis. Hypoxia types and chorioamnionitis consist of major part of CTG abnormalities. If you are comfortable in managing these two conditions, most of your babies can be managed safely. Other things are rare. So we are focusing most of our time discussing these two entities because most of the time our babies are having problems associated with hypoxia and chorioamnionitis. Fetal anemia, fetal acute blood loss like vasoprevia, cardiac arrhythmia, neurology, they're absolutely rare. You know, they're not common in our day-to-day practice. So we'll focus mainly about those two entities, but we will discuss others as well. That's for tomorrow. Today we are focusing about hypoxia. So try to make a diagnosis what is happening with the baby. That is our aim. And then plan accordingly. It could be eliminating any stressors. It could be delivering the baby. It can be anything. We are not sticking to a particular pattern. What we are trying to do is trying to understand what is happening with the baby and act accordingly. That is the beauty of physiological interpretation. The liberty or freedom is there for us to decide what to do. We are not restricted to a particular box. Okay, look, if you see this pattern, you have to do this thing. There's nothing like that because we have to individualize. We have to think about that particular baby, what risk that mother has, what risk this baby has, and then plan it according to the individual risk factors to that particular baby, not in general. Okay. To interpret CTGs physiologically, I mean, we all know these features. We all know these features, but I will take you through, we'll think about them in a slightly different way, because we all know these features in CTGs, but the difference is how it affects the baby when it comes to hypoxia, when it comes to chorioamnionitis. We think in a slightly different way than when we were following nice guidance. So let's take one by one and see what's the difference. Baseline heart rate, very important. We all know for a long period of time, we know term babies have a baseline heart rate between 110 and 160. We have studied this. I have studied this for my MS exam, MRCOG. So it's like, got known factors. We know that 110 and 160 is normal. But there were instances, the babies who had a baseline heart rate, like for an instance, if I say 40 weeks plus 10 days baby, will have a heart rate closer to 110. So this is the difference, that 110, for instance, we say it's 120, that baby's heart rate, if it goes up to 120 or 130, that is significant. But if I think, okay, that is still within the normal limit, why would I bother? That's where I get into trouble. If baby's heart rate is 110 or 120, which become 130 or 140 is significant. Why it happens? you have to always think, what is the appropriate fetal heart rate for this particular baby? The simple way to remember is if the baby is term plus, it is more closer to 110, but if the baby is closer to 37, 38 weeks, it could be more closer to 160, maybe 150, 140, but some idea will be helpful. Now, this is something we try very hard to establish in clinical practice. Whenever you see a term baby in the antenatal clinic, or if they come to maternity triage, for some reason, always document the baseline heart rate. If you see a patient in the antenatal clinic 36 weeks onwards, if you listen to the baby's heart rate, either by PNAD or Doppler, whatever it is, listen to at least 30 seconds if 1 minute is too long. And I think 10 seconds or 15 seconds not enough. At least listen to half a minute, multiply it by 2, and document that number. We have a habit of writing fetal heart rate regularly, FHHR, but that's not helping. Knowing that fetal heart rate, baseline heart rate, is very useful and very important when we face challenges later on, because that's the general heart rate of that baby. How it changes later on, when the baby comes in labor, whether baby comes with hypoxic insult or whatever it is, we can interpret that if you know the baseline heart rate. So remember, if you auscultate, if you listen, if you do a CTG, document that heart rate. That is really important. And to always think whether that heart rate is appropriate for the gestation. Variability, what does that mean? We know variability is between 5 and 25. This baseline variability is controlled by the autonomic nervous system. It's a balance between sympathetic and parasympathetic system. If the sympathetic and parasympathetic system coordinate well, and heart rate varies, like an adult, our heart rates are constantly fluctuating. So if that happens to the baby, that baby is a healthy baby. So if the variability is between 5 and 25, it is accepted, it's a long known factor, that baby is a healthy baby. Baseline variability can be reduced, rarely it can be absent, or it can be increased. It can be more than 25. So then we call these abnormal patterns sinusoidal patterns, pseudosinusoidal patterns, zigzag pattern, which is a recent definition. Zigzag pattern is a transient sinusoidal pattern. There's a big oscillation of baseline due to autonomic instability. It can be due to hypoxia, profound hypoxia, or chorioamnionitis. Those are new changes came into the physiological interpretation. So baseline variability is a function of autonomic nervous system. Baseline variability changes signifies the changes happening at the autonomic nervous system. So it could be hypoxia, choreo, whatever it is, maybe medications. We'll come to that. Just remember that feature, baseline variability. Now we all know about accelerations. By definition, it should be 15 beats into 15 seconds. It's a healthy sign. Acceleration is a function of a somatic nervous system. Babies move, twist, turn, sometimes do various things. Every time the heart rate can go up. So if you see accelerations, that's a healthy sign. Absence of acceleration is not an unhealthy sign. So if you see them, it's good. But if you don't see them, it doesn't mean that baby is ill. Now, one thing came up with new nice guidance and even physiology. We discussed that accelerations are used something, kind of instead of scalp blood sampling. If you examine a patient, if you stimulate the fetal scalp, if you see an acceleration, that baby is not hypoxic. So that can be used instead of fetal blood sampling, because if you stimulate the fetal scalp, baby's heart rate should go up because it's stimulating the baby. It's the effect of somatic nervous system. There are some upward deflections appear like accelerations, but they are not accelerations. if you see decelerations due to cord compression, we call it, typical variable decelerations with shouldering. Those shoulders are not accelerations. Some people mistake that for accelerations. And sometimes, very interestingly, maternal heart rate can be mistaken for accelerations, because you may be monitoring maternal heart instead of the baby's heart in the CTG. So if you see an acceleration coinciding with contractions, it is never an acceleration. So acceleration should not coincide with contractions. If you see acceleration coinciding with a contraction, that is not a true acceleration. That can be either maternal heart. If you rule out maternal heart, it could be an interesting condition called cord compression, cord vein compression. I have a slide I'll show you. Because if the cord vein, umbilical cord has cord artery and cord vein is more thinner than the artery, which can be compressed easily. If a cord vein is compressed partially, or cord is compressed partially, only the veins are compressed, not the arteries, the blood supply to the baby is cut off. So baby's baroreceptors recognize that as a hypotensive situation, and it will increase the heart rate. So that is not an acceleration. All that tells is, okay, look, the cord is getting compressed. So you've got to prepare for changes in future as you carry on monitoring. I'll show you, that's an interesting trace. This is also very easily, this can be missed. Let me see. I'll show you acceleration first. These are the true accelerations. Good baseline. Baseline is appropriate for the gestation. And I think these are term babies, it's about 140. And you see these sporadic accelerations with good variability. They're not coinciding with the contractions. 15 beats into 15 seconds, true accelerations. What about this? The encircled ones, the black ones at the beginning. They are coinciding with the contractions, and they don't appear like true accelerations. So this is the cord compression, cord vein compression I mentioned earlier. So they are not true accelerations. So look at what happened after that. It developed into a profound deceleration. So if you see this, that means the cord is pressing somewhere. Think about that. They're called spurious accelerations. Just to remember, too many features, just to have some idea. We will discuss this again and again. Decelerations. Why do we have decelerations to the baby? Babies need to have decelerations because placenta acts as the pair of lungs for the baby. They don't have access to the environmental oxygen. Baby has to depend for the oxygenation. The oxygen comes through the placenta. These protective receptors will protect the myocardium if there is an insult either with the pressure or with the hypoxic stimulation. If the pressure goes up, heart rate comes down, because when the pressure is high, if the heart is trying to beat at the same rate, will end up with myocardial injury. So immediately the heart rate will go down. But if the pressure is dropped, cardiac output has to be maintained, so heart rate will be increased. That's the job of the baroreceptors. Chemoreceptors, slow to react because it senses the partial pressure of the oxygen, carbon dioxide, and lactic acid in the circulation. So they are slow to recognize that it's not a neurologically mediated, chemically mediated, and slow to recover once the insult is disappeared. So that's why they're a bit late. They're broad-shaped. The baroreceptor decelerations are V-shaped. Chemoreceptor decelerations are U-shaped. When I teach in the CTG teaching, I always tell my trainees and the midwives and all that who come to the CTG workshops, the baroreceptor decelerations are a bit like parking sensor. Baroreceptors are like parking sensors. When you reverse, the parking sensor will beep straight away. So the response is immediate. Chemoreceptors are like smoke alarms, smoke detectors. The sensation, the smoke alarm do not get triggered off immediately. It take a little while until the smoke concentration increased up to that particular threshold. And even if the smoke disappeared, it takes a while to stop beeping. So chemoreceptors are a bit like that. So remember that example. So you know that baroreceptors are prompt to recognize the change and prompt to recover once the desired effect is achieved. Chemoreceptors, slow to recognize, slow to recover. And there are combined baroreceptor and chemoreceptor deceleration. Sometimes it can be a bit complicated to recognize unless you're careful. But that's rare. But remember, baroreceptor decelerations are the more common ones. When you develop chemoreceptors, that means the hypoxia is developing the baby. Excellent. This is a deceleration, classical deceleration of a cord compression. I will take a little time to explain this. I'm sure you must be knowing this, but let me quickly go through this. What happens if the umbilical cord is getting pressed? The umbilical cord, we know there are two veins and one artery. Artery is thick-walled, but the veins are thin-walled. Veins bring blood to the baby, arteries move blood away from the baby. When the contraction is building up, the initially veins will be compressed because they are thin-walled. So what happens when the veins get compressed? The blood won't come to the baby. So baroreceptors will trigger off. So recognize this hypotensive state because the blood doesn't come to the baby, and it will increase the heart rate. So initially the heart rate will go up. Then as the contraction develops further, it will compress the artery also. So what will happen when the artery is compressed? When the artery is compressed, the blood cannot go out from the baby. So the blood will accumulate within the baby. So that will increase the blood pressure. So baby has to protect the myocardium, so has to drop the heart rate. So initially it is upward deflection, then it will drop like a deceleration. So the contraction will sustain for a little while, the deceleration will be maintained. Once the contraction is easing off, which one to get released first? The first to get released is the artery, because it needs the stronger contraction to keep contracted. So initially, artery will be released. When the artery get released, blood will be pumped out, and the heart rate will go up to the baseline. And it will go beyond the baseline because the vein is still contracted. When the circulatory volume is established after the release of the vein, also, heart rate will come back to the normal level. You need to understand what's happening there. Then only you can interpret the CTG. Is it clear? Or is it too much or too many details? Just have some idea. So cord has 3 vessels, 2 veins, 2 arteries. Try and figure it out. When you think about that, when you think what happens with the beginning of the contraction, veins get compressed, then arteries get compressed, then the sustained period of contraction, then contraction slowly eases off, artery get initially released. What happens? Then the vein get released, comes back to normal. So this is entirely a physiological mechanism. There's no hypoxia involved in this. If you see this kind of deceleration, there's no hypoxia. Let's move on. Yeah, these are the decelerations. So if you see these decelerations, there are multiple decelerations. You see shouldering, prompt recovery to baseline, coinciding with the contraction, entirely physiological. You don't need to worry about this. But the worry is, you know that cord is getting pressed. That's why you see these decelerations. Now we have to individualize this situation to the baby. Now, what will happen to this particular baby? So we can think about different clinical scenarios. If you see this kind of picture in early labor, it's slightly worrying because baby has a long journey to go. But if you see this 8-9 centimeters in a multi, you probably think baby will get away because baby will be able to withstand. If baby could withstand journey up to that point, it's not long to go. So as long as the baseline is maintained and the variability is maintained, there is no hypoxia. Forget about decelerations. When Edwin is doing master classes, he's always telling, get a coin and cover the decelerations. You don't need to worry about the decelerations. If you manage these kind of patients in low risk pathway, like midwifery care, if midwives are looking after these patients, they won't see these decelerations because you are meant to listen to the fetal heart after contraction. When you are intermittently auscultating, two things you need to focus on. One is the fetal heart rate, other one is decelerations. We are not worried about the baroreceptor decelerations when it comes to intermittent auscultation. We are only worried about the chemoreceptor deceleration. That is why the instructions are given clearly to midwives. Listen after the end of the contraction for 1 minute, because we don't want to catch that baroreceptor deceleration. If the baseline is satisfactory, when the woman comes to the labor ward, they check the baseline. If the baseline is staying at the same level, if it's 150 at the beginning, and even when you check now, still it's 150. And there are no decelerations when you listen after the contraction, that baby is fine. Maintaining that baseline, and there are no chemoreceptor decelerations. That's all you can check from intermittent auscultation. You can't check variability. You can kind of pick accelerations, but soon after contraction, you don't pick accelerations. Accelerations happen in between contraction. We are not looking for accelerations. We are looking for chemoreceptor decelerations. So if you are intermittently auscultating, these babies will go unnoticed. But if you are putting in the monitor, you will see this picture. The key thing is, if the contractions come more frequently and more strongly, then hypoxia can develop, because when umbilical cord is pressed or stretched, you see the variable decelerations, but when the uterus relaxes, they get filled. So the oxygenation will be maintained. But if the contractions come more regularly and more frequently, that filling time can be affected. That's where the hypoxia develops. So remember that if you see this picture, at the moment, there's no problem. But if the labor journey is a long way away, then we got to be thinking, okay, look, will there be problems as I go on? So I have to constantly at it and monitor this baby. That's the difference. Let me move on. So then comes to the more kind of sinister decelerations. So, more important decelerations, the chemoreceptor triggered decelerations. As we discussed, they're late to come, late to recover. And let me see, yeah. They're not nice. So as you see, they start with the contractions, but even after the contraction eases off, they won't return back to the baseline straight away. It takes time. It's lagging behind the contraction because it's sensed by chemoreceptors. If you see these kind of decelerations, that means the hypoxia is developing in the baby. And we don't need to rely on chemoreceptor decelerations. Together with this, we will see rising baseline, like in this case, and eventually the variability get affected because development of hypoxia. So we put all the features together and try to understand what is happening with the baby. We are not particularly pointing out about the decel. We take decelerations into account, but we try to understand what is happening with the baby. That is physiology. Cycling. Cycling is, again, is between the sleep and activity. It's a healthy sign. Just remember that. It is activity of the brain. So healthy brain shows cycling. And cycling is one thing to disappear in chorioamnionitis because of the inflammation of the neurological system. It's more important in chorio than hypoxia. But remember, cycling, if you see cycling, most of the times we see people get worried and panicked and all that, seeing a flat CTG, but the flat CTG should be there for more than 50 minutes to be abnormal. If the flat CTG is half an hour, then you get the variability. That is cycling. That's a very healthy sign. Nothing to worry about that. It's a wake-sleep cycle. Hypoxia types, different 4 types we talk about. Chronic hypoxia, gradual evolving hypoxia, subacute hypoxia, acute hypoxia. We'll discuss one by one what they mean. Right. Imagine a situation, you are coming in the morning, labor ward full of ladies. Maybe 5, 10, 15, depending on the institution you work. We compare that as the kind of a beginning of a marathon. It's a kind of a marathon, isn't it, labor? It's a very strenuous journey. Some will finish it early, finish it easily, some not easily, but healthily. Some will struggle. But we don't know who is going to be struggling, so we need to monitor them. Now, this is at the beginning. We have a cohort of mothers with different kinds of situations, babies of different reserves. We don't know. We know some of them are high risk. We know some are diabetics, pre-eclamptic, growth restricted. We know some high risk mothers we can select and monitor them closely. There's another group of low risk mothers. They are healthy. They will go through this journey well. The babies are healthy, placenta is healthy. They won't have any problems. Some will get into problems as we go on because late onset placental insufficiency sometimes go unnoticed. It will only manifest when we put strain on the baby. But one big task at the beginning of the journey, beginning of the marathon, is to exclude one type of hypoxia, and that is chronic hypoxia. We all know that how important it is. These babies are unhealthy. They are chronically hypoxic because hypoxia has been developed within the intrauterine period. Probably it went unnoticed, maybe hours, days, we don't know. But when they come to labor ward, we need to pick this. Our midwives are very good to detect fetal heart rate, even if they're on the low risk pathway. They will be able to tell this baseline heart rate is appropriate for gestation or not. Oh, this heart rate is high. I'm not happy with that. We know this group of high-risk mothers. We know these high-risk babies, but sometimes even a low-risk baby can show chronic hypoxia. How does it appear? We all know that chronic hypoxia has raised baseline. It is much more higher than the expected baseline for gestation. For an instance, if a term plus 10 baby comes, the baseline of 140, 150 is very important, is high, because you expect it to be 110, 120. 150 is higher for that baby. If a midwife detect higher baseline for that baby, we need to put the monitor and see. Then you see this reduced variability and the shallow decelerations. We saw some decelerations earlier, but compared to that, these decelerations are very shallow because metabolic acidosis has settled in. The myocardium cannot contract, heart cannot contract faster, so the decelerations are very shallow. So this is not a good situation. These babies are already compromised, so they cannot go through this journey. If you see this picture, immediately deliver them. There is no choice. Because if you subject them to labor, they can get brain damaged because they are already very vulnerable, already hypoxic. Don't break waters, expecting them to go through labor and show more decelerations. That is not going to help them. That will cause more damage. If you see this picture, you have to deliver them by cesarean. Chronic hypoxia. So we have a toolkit. We got this from physiology website. At the beginning of the labor, we always use this toolkit. We always use this sticker, in the notes. You can download this from physiology website. We will give you the details. So whole idea is, number one is see whether the baseline appropriate for gestational age, whether there's a variability and cycling, presence of acceleration. But to do this, you need to have a CTG strain. I don't know, some units practice admission CTG, I don't know. But at least even if you auscultate intermittently, if you find a baby whose heart rate is higher than the expected gestation, always do a CTG. Then put this sticker, you will get these features, you can make the diagnosis. The next category is gradual evolving hypoxia. Now, if we exclude this group of babies who are chronically hypoxic, then we get the group of healthy babies. In that healthy babies, some may be high-risk babies. High-risk babies will be having continuous monitoring, maybe diabetics, preeclamptic, non-IUGR. But there'll be some babies have placentas who has late onset development of fetal compromise. They are healthy grown babies, but last couple of weeks time, some compromise of the placenta. Placental function is not optimal. So they can show evidence of hypoxia in labor when the stress come into the picture. Another group of babies can have problems with umbilical cord. Growth-restricted babies are more prone to get umbilical cord compression, but even a healthy baby can get umbilical cord compression. Sometimes the cord can be wrapped around neck or arm or body or multiple times. Those babies can get hypoxic very easily. So whatever the reason, if chronic hypoxia is not there, the next challenge is detecting this evolving hypoxia. It's a gradual process, gradually evolving hypoxia. How does that happen? Now, what do you think about this CTG? I would say the baseline is 140, good variability, plenty of accelerations. So healthy baby at the beginning of the journey, we would say it's a 32-year-old multip who is in her third pregnancy, came with labor pains. You can see some contractions. So to start with, CTG is fine. There's no hypoxia. What will happen as we go on? It will stay like this, or if there is a placental or cord compromise, you might see some changes. As we go on, maybe a couple of hours later, she's contracting spontaneously, you will see these decelerations. Baseline is more or less the same, and variability is maintained, okay? But you see some decelerations. What type of decelerations are they? They're baroreceptor decelerations. They're not chemoreceptor. Is the baby hypoxic at the moment? No. If the baby okay, baby's absolutely fine. Are we worried? We have some concerns because if she's 3-4 centimeters dilated, she has a long way to go. It may be a rapid labor in the previous delivery. That will be helpful to know. If she's primate, if she's 3-4 centimeters dilated, we know she has a long way to go. So we have to be mindful about the time scale. But we have to monitor this baby carefully. At the moment, if you ask me whether there's hypoxia, there is no hypoxia because of two factors. Baseline stays the same and variability is maintained. Even nice guidance, the 2022 one, clearly says if the baseline stays the same, variability is maintained, chance of hypoxia is negligible. So we take that into account. So what will happen when the labor goes on? Right, that is interesting. If I say the baseline has risen up to 150, 155, now the variability is a lot reduced and the decelerations are getting prolonged to recover and they don't look nice. So they are much broader, slow to recover. They're more kind of chemoreceptor mixed type of decelerations. What is happening there? Now we try to understand what is happening with the baby. Why baby is having these decelerations? Why baby is having this picture? So hypoxic stress is coming into the picture now. Earlier baby was compensating well, but now the baseline has gone up, variability has reduced. Baseline has gone up due to the sympathetic drive or the adrenaline drive. Variability is reduced because of the development of metabolic acidosis at the autonomic nervous system. It cannot function properly, so the variability cannot be maintained. Because chemoreceptors are sensing hypoxia developing, it will throw chemoreceptor-triggered decelerations. So compensated baby earlier will become decompensated now. So what can you do in a situation like this? Well, if the baby is fully dilated, head is visible, you can put a forceps or want to sew something like that and deliver the baby. But if not, we know these changes are secondary to the stress of the contractions. So we can ease off the contractions. How can we do that? If she's on oxytocin, for some reason, we can stop oxytocin because oxytocin generated contractions are strong. And when the mother is on oxytocin, in between contractions, the tone of the uterus don't come back to normal. There is some kind of tone maintained even in between contractions. So hypoxia can develop very quickly. And as labor progresses, the oxytocin receptors become more and more, develop more and more, and the sensitivity become more and more. So the contractions become frequent and stronger as the labor continues. So that's why if you don't do anything, this picture develops. So we can lessen that effect. We can give tocolysis. We can reverse the effect of contractions. In our settings, we use terbutaline. I don't know whether terbutaline you guys use, but I know salbutamol can be used. There is a regime. Asela will discuss that. Is tocolysis, relaxes the uterine muscle. So trying to reverse the effects, because if we know this is secondary to contractions, we can reduce the strength of the contractions and see whether baby improves. So like that, this is the beauty of physiological interpretation. You understand what is happening with the baby and act accordingly. There is no hard and fast rule. If you see this, got to deliver. There's nothing like that. You're trying to figure out what is happening, and if you can reverse them. Now, what the measures I mentioned, stopping oxytocin, we can give a fast saline flow to dilute the effect of oxytocin, and give tocolysis. All measures are trying to reverse the effects of contractions. So it's kind of intrauterine resuscitation rather than delivering the baby. Once you improve the CTG, if you can take the CTG back to this stage, that baby is fine. So if she's 8-9 centimeters, we can lessen the effect of contractions and let the labor carry on. So it's a hi Darshana. You're mute.
Yeah. Is there any particular time duration you recommend if you find a chemoreceptor deceleration with CTG with us?
Not really. No. Like, imagine if you come across a situation, now so many variables now. So the mother can be on oxytocin, yeah, or mother can be contracting spontaneously. We have to understand what is happening with the baby. Whether these increased contractions are caused by an abruption or something like that, then there is hardly any time to waste, So we have to figure out what is happening. If this comes with a little bit of bleeding PV, it could be an abruption. So then don't try tocolysis, might as well deliver. So highly individualistic approach. Now, if you see chemoreceptor decelerations at fully dilatation, you deliver the baby. You can ask mother not to push because pushing increases the hypoxic strain. If she's on oxytocin, stop that. If you want to buy some time, give a shot of terbutaline or salbutamol, ease the burden because, you have to organize instrumental delivery. It might take 10-15 minutes. So you have to highly individualize. That is the physiology. It's kind of pathophysiology, but for simplicity of use, we call it physiology. Well, this is more than physiology. So trying to figure out what is happening with the baby and try to understand what can help the baby, So if it's a primate, if you see this situation in a primate, 2-3 centimeters dilated, we know very unlikely because we don't know how many hours she takes to go through the labor. So it's very unlikely if you develop chemoreceptor decelerations at 2-3 centimeters, she's very unlikely to go through the labor. But if she's a multi who had a quick labor last time, if she's 9 centimeters now, you try to lessen the effect of contractions and give her another couple of hours and see whether she becomes fully dilated. If she's fully dilated, you can do an instrumental delivery. Yeah. So there is no particular set pattern to follow. That is the beauty of physiology. So you understand the principles behind physiological interpretation, use it to the individual situation. And based on your knowledge, you make a management plan. It might work, it might not work, but most of the times it works. It's a learning curve, isn't it, for everything? Clear? Okay, thank you. So if nothing is done at this stage, now, metabolic acidosis, we can see the effect of metabolic acidosis. Heart is struggling, brain is struggling, variability cannot be maintained, chemoreceptor decelerations are playing into the picture. If you don't do anything, what will happen? When heart will struggle to maintain the rate, so you will get this thing called step ladder pattern, and the heart rate eventually drop, and baby will die if you don't do anything. This is what will happen if the hypoxic insult continues gradually, if you don't do anything. That's again is depending on the fetal reserve, degree of contractions, the lots of things. But when you come to this stage, very little you can do to help the baby, because baby is already massively acidotic, probably brain damage has already taken place. So we should act before coming to this stage. If you come up to this stage with this, gradual dropping of the heart rate, we call it step ladder dropping, then actually brain damage would have taken place at that stage. Yeah. So you have to act before that. This is a kind of irreversible stage. We have to act before this stage. Right. Okay. So we use this sticker. This is again given in the physiology website. Every time when you see a CTG, these parameters, you go through each and every one, try to understand what is happening with the baby. It's like a checklist. So if you miss something, the checklist will tell you, look, you need to look into these features. We talk about baseline, accelerations, decelerations, whether there's a rise in baseline more than 10%, intercontractile. They're all features we look in the trace, CTG, just to check whether the oxygenation is maintained. If there are other factors, then we'll document that as well. Then we'll suggest a management plan, whether we are reviewing in 2 hours, 4 hours, whatever it is. We recommend a management plan. If you think there is a hypoxia, what we need to do, we need to resuscitate, we need to deliver. So whatever the management plan, we document that. And this is a kind of a checklist every time when you review a CTG for helping us to go through each and every component. All these things are available in the physiology website. We use this in our hospital and it's really useful. I'm going to tell you a few words about intermittent auscultation. I've told about intermittent auscultation. In units, high-risk mothers, we use continuous monitoring. I heard from Asela that most of our units have continuous monitoring, and though we don't use CTG strips, the computer system records the monitoring. That is more than enough, actually. Physiological interpretation, that's all you need. You don't need anything else. So that's exactly what we do in UK. Low-risk mothers are looked after by midwives with intermittent auscultation. CTG is used for high-risk mothers. So anybody crossing the low-risk pathway to high-risk pathway, then we have to monitor them with CTG monitoring. So intermittent auscultation, actually, this is called intelligent auscultation now. We are intelligently, particularly look for that chemoreceptor deceleration, particularly look for that rising baseline. That's why I said whenever you see a mother after 36 weeks, always listen to heart rate and document what the baseline is. Compared to that only we can say the baseline is rising. It is very difficult to say unless baseline is disproportionately higher, the baseline has risen when you see the mother for the first time. So if you are documented beforehand in antenatal notes, it's a lot easier to compare that and see. The recommendation is listen to baby's heart every 15 minutes in the first stage and every 5 minutes in the second stage. I'm not sure it's the same practice in Sri Lanka, but this is what we do here. I think if we use intermittent auscultation intelligently, we can, if we educate our midwives how to use it and how to highlight if there's a concern, that cohort of babies who get into chronic hypoxia, cohort of babies getting into gradually hypoxia when it comes to decompensatory state, we can pick them up. Then we can act but it's kind of a, if we can have a guidance, okay, look, if you see these things, you need to inform us, we need to put them on the monitor, then we can put them in the high risk pathway. Either we can deliver, we can give tocolysis, whatever the action we need to do, we can decide. But this is kind of from intermittent auscultation, we can figure out or filter that high risk babies from the low risk mothers, low risk babies who go through this process without any problem. I think it will work. Right, okay, I'm handing over to my colleague Asela now to carry on with acute hypoxia. At the end of it, if there are questions, we are more than happy to answer about other hypoxias. He will discuss acute and subacute hypoxia.
Yeah, thank you, Mr. Priyant. So excellent presentation. And how many minutes we have actually? I think it's 25 minutes, probably.
No, it's all right, Buddhika. So you can go ahead. It's all right.
Okay, so I think we will discuss Darshan's question later. So I might can add some for me as well. When I was a trainee in UK, so that was the main problem for me as well, because we know that we can deal with the chronic, we can deal with the acute, we can deal with the subacute, but for the gradual evolving, the main problem was when to deliver actually. So that was inside my mind. So there are some sort of answers in the Edwin Chandraran's CTG book, so we can discuss that. So we go to the acute hypoxia. It's a kind of obstetric emergency. It's not like the gradual evolving. So even the obstetrician or even the attending doctor will no have a clue regarding what is going to happen this patient. So that is a kind of obstetric emergency. So what you see with the acute hypoxia is you see in the CTG is a prolonged deceleration. So prolonged deceleration means these are some deficits, sudden abrupt decrease in the fetal heart rate. Especially, it's usually more than 30 beats per minute and persisting longer than 3 minutes. So the FIGO guideline says it's 5 minutes and some American guideline says it's 2 minutes, but we use the 3 minute traditionally. And what happened when the prolonged deceleration persists more than 10 minutes, we call it terminal bradycardia. And it shouldn't be confused with the fetal bradycardia, what we discuss in the normal baseline heart rate. Okay, so this is terminal bradycardia, usually follows the prolonged deceleration if it is lasting more than 10 minutes. Next slide. So I think, so the physiology behind the acute hypoxia is quite complex, but the babies in the gradually evolving hypoxia. So in this situation, suddenly, acutely, there will be a loss of blood supply or loss of oxygen supply. That will be acute. So in that particular time, as a backup plan, we will directly activate the vagal nerve and send the impulse to the AV node and create a deceleration. As Mr. Priyant explained, the decelerations are always cardioprotective because if the baby's heart worked in a rate like 120, 130 with the low oxygen concentration, the heart muscle will go into metabolic crisis, anaerobic metabolism, lactic acidosis. That is why baby is trying to slow down the heart rate, slow down the workload of the cardiac muscle to buy a reasonable time until someone bail out the baby. So same time, there will be a chemoreceptor mediated reflex supporting the deceleration. So can we go into next? Yeah, again. Okay. So if we think about the causes for the acute prolonged deceleration, there will be two type of causes. That's what you need to understand. There will be two type of causes. Depending on the cause variety, your outcome will be different and your action will be different. So your main aim is to identify what causes we are dealing with. So there are irreversible causes. Irreversible mean like someone tie your hands and legs and push you into the water tank. So you can't come out. There should be someone to take you out. So likewise, irreversible causes, the baby cannot do anything. So you need to take the baby out. So that is irreversible, like abruption, cord prolapse, uterine rupture, acute pituitary hemorrhage, and sometimes the gradually evolving hypoxia can also go into acute prolonged deceleration and acute hypoxia, and rupture of vasa previa, and the end stage of chorioamnionitis. So again, there are reversible causes like hyperstimulation, that is one of the most common cause, and the maternal hypotension, not much common in Sri Lanka, but when we work in the UK, you can see after the epidural, you might get a sudden bleed, then that is acute deceleration. But when you resuscitate the mother, when you change the position, then it will improve. So sustained cord compression and hypothermia, hypoglycemia, and sometime after the external cephalic version, you can get these acute prolonged deceleration. So depending on the cause, your action will be varies. Yes. So the fetus, even with the acute or abrupt or complete block of the umbilical cord, there are mechanisms that fetus can survive certain amount of time. So these are the adaptive mechanisms that plays a really marvelous role inside the baby's body during this type of situation. So ductus venosus and the foramen ovale, so it shunt the blood from left atrium and left ventricle to the system. It bypasses the right ventricle. So that is one adaptive mechanism. And the ductus arteriosus, deoxygenated blood directly go to the descending aorta and bypassing the lung. It exchanges carbon dioxide. And also, especially hemoglobin level, the higher concentration of fetal hemoglobin, which has an increased capacity of carrying oxygen, and also which acts on the low oxygen partial pressure, which release the oxygen even in the low oxygen partial pressure. And also it is a good buffering system. So it prevent from the acidosis. So as we mentioned, the deceleration, which is always a cardioprotective, which works to protect the myocardium. And the catecholamine surge, but not in the acute deceleration, but in the gradually evolving hypoxia, the catecholamine surge will try to increase the heart rate and supply the oxygenation. So these are the adaptive mechanisms that babies having during decelerations, not only in the acute, but also in the gradually evolving type of deceleration. Yes. Okay. So when it's come to the real assessment, when you see the acute deceleration, you need to think, first you need to exclude what is the cause, whether it is reversible or irreversible. If it is irreversible, there is no point of thinking any of this. You need to deliver the baby. But if the cause is of CTG, to identify whether there is a possibility that this baby will recover in given certain time. So you can check the fetal heart rate variability before the onset of the prolonged deceleration. What does that mean? If the baby is having a normal fetal heart rate variability before the onset of the prolonged deceleration, that means that baby is having a good intact neurological system, autonomic system, good oxygen reservoir. Sometimes babies go into prolonged deceleration following a gradually evolving hypoxia. In that kind of situation, baby does not have enough reservoir to cope with the prolonged deceleration. So you need to individualize deceleration depending on the previous part of the CT. And the fetal heart rate variability within the first 3 minutes of prolonged deceleration. So if the variability within the first 3 minutes of the deceleration is normal, that means there is higher chance that this baby might recover with the conservative measures. And also depth of the prolonged deceleration and the duration of the prolonged deceleration. So we will discuss it later. Can you go to next slide, please? So these are the features, the variability before and within the deceleration. You can see two CTGs. One of the right side CTG with the arrows indicate the fairly good variability of the CTG before and within the deceleration, and it has recovered. But on the left side one, you can see it. The baby is coming with a low oxygen storage, low oxygen reservoir. There are decelerations, and also the variability is reduced, and the variabilities within the prolonged deceleration also reduced. So the chances of recovering this CTG is very less. So that is how you individualize your acute prolonged deceleration. Next. So depth of the deceleration, there are a lot of evidence. If you read the articles, you can see regarding the certain cutoff limits, 60, 70, 80. At the 60, if the fetal heart rate drops below 60, that means there is a 3% chance that baby get threefold increased risk of baby getting acidosis. Considering all this evidence, they have developed a cutoff that if the fetal heart rate drop below 80 beats per minute, immediate measurement should be taken to facilitate the recovery. That is for the fetal safety. Yes. Next one. Okay. So I think this is something important for us to discuss. And management of uterine hyperstimulation. We face a lot of problems with managing uterine hyperstimulation because I think we don't have proper registered tocolysis at the moment. If I am wrong, somebody can correct me. But the management of uterine hyperstimulation mainly is the contraction. We can stop the oxytocin. Sometimes we give the fluid, but there are no much of evidence for giving fluid and the diluting the oxytocin hormone inside the body, but still we practice that. So we only take out the prostaglandin, or we only stop the oxytocin. That is the most evident method we do at the moment. But in UK, we use terbutaline. That is a wonderful, marvelous drug actually, which I saw last 2 years. So I think we have prevented a lot of cesarean section using the terbutaline during that time. So actually, so there are other things that we can use, like nitroglycerin, that is GTN. Sometimes you can use the GTN. I heard some unit practice in GTN, but it has a short action, like 1 to 2 minutes. So actually, to ease the contraction, at least you should have 15 to 30 minute duration of action. That is how baby recovered. 1 to 2 minutes of action, that might not do the great job, but still that is something you can try. And regarding the salbutamol, there was one hospital used the salbutamol in UK, 100 micrograms intravenous or inhalation. So I checked with the BNF. It says even the salbutamol can be used for the reducing contraction in the preterm labor. So if we see the ECV guideline, there are pragmatic regimes of the salbutamol, 250 micrograms with the 25 ml of normal saline using IV before the ECV. So I think the salbutamol is one of the medication we can use for acute tocolysis, but probably we need to find a correct regime, which we can do later. So these are the medication we can use for the tocolysis.
That is very important. Can I few points? With tocolysis, when we started tocolysis in our hospital, it took a long time to, because there were lots of resistance initially to give even terbutaline. But once people are getting used to use it, they really use it and they enjoy the effects. Now, Asela, we have witnessed it. We use it very liberally. Even midwives are encouraged to give terbutaline. You don't need a doctor to give terbutaline. But you got to bear in mind, you have to be very careful because this can increase maternal heart, not to give it to mothers with, tachyarrhythmias and all that who are prone to have cardiac arrhythmias. And if baby has chorioamnionitis, be careful. That can push babies into arrhythmias because their heart rate is high. So there are a few issues with tocolysis, but generally it's a very safe drug. We hardly see problems and it works really well to reverse these effects of hypoxia. Thank you, Asela.
Yeah, especially when we give it in the second stage of labor, I think, with the subacute hypoxia. So it really is the contraction, and by significant amount of time, and then the baby's acid-base balance will be normal once we deliver the baby, because intrauterine resuscitation is much faster than extrauterine resuscitation. So giving oxygen in the outside to the baby is much slower. But in the fetal-placental unit, the acid-base balance will correct very quickly. So once we give the terbutaline, we have seen that the most of the time the cord pH has been really coming to the normal. That sometimes does not tally with the CTG picture even. Next slide. So this is the suggested management for acute prolonged deceleration. So once you see it, then you immediately check the mother's conditions like airway, breathing, circulation to exclude any acute profound blood loss, so hypovolemia. And then you can do the abdominal examination and the vaginal examination to exclude any cause of placental abruption or uterine rupture. And then you do the vaginal examination to exclude cord prolapse. So once you exclude if you identify any irreversible cause like placental abruption, cord prolapse, uterine rupture, or vasa previa, then you need to deliver that baby quickly in the safest and the quickest way. Either it will be an instrumental delivery, either it will be a cesarean delivery. But if you identify that this is a reversible cause, mostly hypotension following a epidural, or hyperstimulation because of the oxytocin, or any other cord compression, then you execute the conservative measures like infusion of saline to correct hypotension, or stop uterotonics and change maternal position, give tocolysis, and then check for the recovery. If the baby is not recovering, then you follow the 3-minute rules. This is the 3-minute rules. So these reversible causes. Once you exclude the irreversible causes, you can follow the 3-minute rules, which means in first 3 minutes, you assess the mother, exclude the causes, irreversible or reversible. Then up to 6 minutes, there is a chance if the baseline is heart rate variability is normal, if the proceeding CTG baseline heart rate is normal, and there is a 90% chance that prolonged deceleration will come into baseline and the recover. So until that time, you continue your conservative measures. So the next 3 minutes, up to 9 minutes, there is a 95% chance that your baby will recover if the preceding baseline is normal and the variability in the 3 minutes is normal. But by that time, at the 9 minute, you should move the patient into theater and be ready for next step. If the baby recover at the 9 minute, then you can discuss the option whether to deliver in cesarean birth or whether to step down onto the labor ward and proceed with the vaginal birth. That should be discussed with the mother and the labor companion as well, and then documented, and then you can proceed with the plan. And after 9 minutes, if the CTG is not recovering, then you should prepare for the delivery. And then with the 15 minute, baby should be delivered. So why the 15-minute cutoff is there? Because with the acute prolonged bradycardia, your pH drop rate is 0.01 per 1 minute. So imagine the baby start journey at around 7.3 pH, and when it take 15 minutes, the baby will be at like 7.15 pH. That will be slightly acidosis. So our aim is to deliver baby without severe acidosis. So at the moment, I think we consider pH 7 is the cutoff. So until pH 7, there are evidence that babies has good outcomes. So that is what we are aiming. So imagine if the baby had bad CTG before the prolonged deceleration. That means the baby's pH already somewhere around 7.2, 7.15 like that. So that is why you need to correlate the previous CTG and decide your action very quickly. Next slide. Okay, so a little bit of regarding neurological injury following prolonged bradycardia, prolonged deceleration. So in late repetitive deceleration, gradually evolving hypoxia, there is a time that baby can adapt the protective mechanism. So baby will protect the basal ganglia and the thalamus with the expense of cerebral cortex and the watershed area. But with the acute fetal bradycardia, there is no time. So the baby's basal ganglia and the thalami will be affected. So the baby will go into severe dyskinetic like cerebral palsy and HI 2-3 stage if we did not bail out the baby. Can we go? Yes. Okay. Yeah. So these are the things we explained. So, okay. So next. So this is the real situation I faced recently. If you can see the CTG here in the monitor, there's a small part of the CTG. The one of my medical officers sent me give a call and said there is a prolonged deceleration, and I have sent the CTG through the WhatsApp. So this is the WhatsApp picture I got. So she's a primips, uncomplicated antenatal care, induction of labor with prostaglandin, then augmented with oxytocin. So far 6 hours of oxytocin and 6 centimeter BMI 32. So these are the details. So when you see this deceleration, what are the positive things that you can point out that this baby might do it well? Or what are the negative things that you can point out this baby will not do it well? So we discuss all the things now. So if you can see the CTG, the variability before the deceleration is quite normal, and already is 5 minutes, I think 5 minutes past, but the variability within the deceleration also normal. And they exclude the acute intrapartum incidents like cord prolapse, uterine rupture, and then this eruption. So, but if you look it carefully, if you observe the CTG carefully, you can see the talker is not properly placed, but you can see the coupling of the contraction. With the coupling, the deceleration has started. So it's most likely due to uterine hyperstimulation. So what we did, we did the stop the oxytocin, we gave the bolus of fluid, then but at the 9 minute, we took the patient to the theater, informed the anesthetic team, and asked them to ready for the general anesthesia because it did not recover until we go into the theater. So luckily, we didn't have, we didn't have the tocolysis, but luckily CTG recovered when we are in the theater around 9 minutes. So the key thing when I learned because of the physiology, the key advantage I got is because I knew I had a positive mind that this CTG might recover within next couple of minutes because there's a normal variability. And also in the theater, I could stop the general anesthesia because I knew that once it recovers, we have time that we can act slowly. So we stop the general anesthesia and we convert into spinal. Imagine giving a general anesthesia for high BMI patient without on-site consultant anesthetic cover. So that will be a little difficult and very risky. So knowing physiology and applying physiology, so we could change even a slight thing that will be more beneficial to patient. So next one.
In this situation, like if you had tocolysis, probably you could have given tocolysis. So that is
Yes,
something.
yes. We would have given it in the labor room, and
Yeah.
then
And
we
probably
might observe the how.
you could have taken her back to the labor ward because she has already dilated up to 6 centimeters. You could have reduced
if
oxytocin. So those are the options you can consider for future practice, So tocolysis, it's difficult to change the culture of using, if difficult to establish that in the practice initially. But when people start using that, they will start enjoying. Then it becomes the normal practice. It is difficult to introduce first, but if you push it, you can introduce. So we need to find the right formula. I think salbutamol is the way to go, isn't it? Because it's widely available in our setting, isn't it? Yeah.
I think we need further discussion regarding
Yeah.
tocolysis.
Yeah. We have taken so many patients back to the labor ward. We have taken so many patients back to the... Sorry?
I think Dr. Galapati has sent some message. So he mentioned that he used nebulization with salbutamol, which works fine. I think. Thank you very much, Dr. Galapati. So there are some
that is mentioned in that Swansea
people
guideline.
using. Yeah, that is. Yeah, that is in the Swansea Bay guideline. So I mentioned that. So I think we need to discuss further and get into this tocolysis business. Then we might be able to reduce a lot of cesarean section.
That's true.
So yeah, let's go. Okay, so that's all about acute hypoxia. I think it's quite simple, but you need to decide whether which baby you are going to follow the 3-minute rules and which baby you are not going to follow the 3-minute rules. And please look for the signs of positivity that baby will recover. So when it comes to subacute hypoxia, so as a definition, we call this if the baby is spending more times during the deceleration, especially more than 90 seconds, rather than spending in the baseline. So usually it's less than 30 seconds in the baseline, more than 90 seconds in the deceleration. So it's almost most of the time it is due to uterine hyperstimulation. So either in the first stage or either in the second stage, most of the time, 90% of the time, this is due to uterine hyperstimulation. So the pH drop rate is 0.01 every 2 to 3 minutes. Is so within 20 to 30 minutes, if the baby starts 7.3 pH, within 20 minutes, then the baby will come to 7.1 pH. So that is what you need to understand. Okay. So management is most of the time it is due to hyperstimulation. If you see the subacute hypoxia, you need to think about the hyperstimulation, remove the prostaglandin or stop the oxytocin. If no improvement, need urgent tocolysis. And if there's still no improvement within 10 to 15 minutes, review the situation and expedite the delivery. So that is for the safety of the baby. And then next slide. Next one. Yeah, next one. If it is during second stage, most of the time you will see the subacute hypoxia during second stage with the active pushing. So you need to stop the pushing. If it is imminent, delivery is imminent. If you wouldn't do the CTG, but you will check with the CTG if the delivery is not imminent. So you need to stop the pushing and give some time for the baby to breathe and correct the acid-base balance. And if no improvement within 10 to 15 minutes, consider tocolysis. And then if the birth is imminent, you can deliver, or otherwise you need to deliver by cesarean section or assisted vaginal.
One thing, there was some anxieties about giving tocolysis, especially we use terbutaline, late first stage, like 9 centimeters and fully dilatation, because some people believe that it can lead to severe postpartum hemorrhage due to uterine relaxation. But we don't experience that. We don't see that because this effect lasts for about half an hour, not more than that. Even if postpartum hemorrhage, if you see postpartum hemorrhage, you can deal with it. But it's better than having a brain damaged baby. So have a liberal, you can liberally consider giving tocolysis if you see hyperstimulation, if you see acute hypoxia or subacute hypoxia, because it is kind of giving a breathing space to the baby. So it is giving an opportunity to get the oxygen to the baby. So, that's the key thing. Intrauterine resuscitation, even if you decide to deliver by instrumental delivery or cesarean section, if you think that 15-20 minutes time I can buy to give some breathing space to the baby, use that tocolysis. Don't worry about postpartum hemorrhage because we can manage that. Very rarely we have seen postpartum hemorrhage due to tocolysis. If there is a post-uterine relaxation, we can always use medications to counteract that. Thank you.
Thank you, Mr. Priyan. Yes. And yeah, so that's all about the hypoxia. So we went through the chronic, gradually evolving, acute, and the subacute. So before going into the questions, there are a few things what I understood, the challenges, but I can see because I learned CTG in last 2 years and I try to practice in Sri Lanka in the Galgamo Hospital and the Madirigiri. So challenges I saw is the knowledge, because if you are the only one in the team have this kind of knowledge, then you have to go through all of the CTG to decide. And sometimes then people will think, or the having a set of the guideline is better, because we can follow the guideline, we can easily deal with that, even the ground level. So the knowledge is one of major problem I realize when I work in these hospitals. Another thing is the one-to-one care. So even we do the continuous monitoring, sometimes we don't have adequate midwife to provide the one-to-one care to check the CTG. That is one major problem. We don't take the print of the CTG most of the time. It runs in the machines. So if you miss something, that is issue. And especially it's resistant to change also. It's not in Sri Lanka and even in the other countries. We considered NICE guideline and the FIGO guidelines are gold standard. So we used to that set of patterns and we used to that the picture, and we know this kind of, if you have this deceleration, you deliver the baby. If you have this, you do this. So that is something very difficult even for me to change. During last 2 years, it took at least 6 to 7 months for me to understand what they are really doing there. So that is those are the things I realize when we try to incorporate physiological CTG, the challenges I face. Next one. Yeah, the suggestion to improve the teaching of the intrapartum physiology and the CTG interpretation, even including with the all the curriculums, if we can incorporate, including undergraduate to midwifery and the postgraduate level, that will make awareness. And the making a CTG reflection platform, I would suggest that is a very, very, very useful thing, because I have witnessed that in the Wales, we did CTG reflection. We did 2 CTG reflection for every week. That is massive learning for the week, actually. It's a critical analysis of a CTG, and we discuss all the things, including the labor pathway and the CTG related to that particular patient. So that is a massive, massive learning platform. If we can develop it, that will be a better option. And the regular small group workshops leading to masterclass, if we can get down the resources, and we can that will be another aspect to boost the likelihood of developing physiological CTG. So those are the things I can suggest. Actually, this is open for discussion. Next one. Yeah. So this is a small change I made in my hospital. This is taken from the physiological CTG guideline. So regularly, even with the small, if I notice something in the patient CTG, then we discuss hypoxic pathway related to that patient. These are the 2 stickers Mr. Priyantha discussed. So the midwives and the medical officers, they always check these things. So it's a small change, but I have seen a slight different result during this period with the small change. So that is something to think about. Thank you very much. I think there will be time for the question. These are the reference articles and the further readings we use for this presentation. So all of these are most updated resources. Most of these are in 2022 and 2023 updated articles and guidelines. Only this physiological one is 2018, others are well updated parts.
The first box is sorry. Sorry, the first box is physiology website. And if anyone wants to find the guidelines about managing these patients, all the guidelines are given in that website. You can print them out like Asela did. Thank you.
Okay, I think that's over. Right. I think it's a end of a very, the fantastic, excellent webinar. I think that was very helpful for us, even the trainees and the consultants. And I am very much thankful to Dr. Priyant and Dr. Buddhika Asela for your very hard work. And so it's quite elaborative. And so I think this is a very good initiative. I am very much agree with you both. And I think our President, sir, Dr. Mangal sir, wants to initiate certain changes to the system. And so if you both can give us suggestions, the sort of make a platform for us to, have a sort of initiation, I think it would be very grateful. And I'm very grateful for, on behalf of the academic committee in the college. And I think, so tomorrow there will be another excellent one, I hope, that also will be very, kind of very helpful for us. And this is non-hypoxic changes in CTG. Am I right, Dr. Priyanta?
Yeah.
So then, again, I'm very much thankful to you both. And so hope for another very excellent presentation tomorrow. And I think, this is time to wind up our webinar.
Any
And-
questions? Any questions asked by anybody? We are happy to answer.
There's one question. And you can give propranolol IV as antidote for terbutaline tocolytic effect. Somebody has suggested, Dr. Bhagya has suggested that.
Yeah. That is the antidote for if you give too much tocolysis, you can reverse that. Like it's a good question. Like if somebody gets postpartum hemorrhage as a result of tocolysis, you can counteract that by propranolol. Yeah, true.
Yeah, okay.
That's
So then Dr. Vasanta Galapati has again mentioned pushing without closing the glottis is an option.
Sorry, pushing
for
without.
the
Closing the glottis is an option.
That's
This regarding the nebulization.
nebulizer
right.
for the salbutamol, I think.
Okay,
Yeah.
thank you.
Thank you very much.
By the some consultants.
Yes, thank you very much for that part. Actually, I can, if we have the Darshan's question, you asked at what point you're going to deliver this gradually evolving hypoxia, isn't it?
Yeah,
So that's I went through this Edwin Chandrana's litigation. There's a part for the medical negligence and the litigation. So if so, I found that it says that with the peak of the heart rate, I mean, the peak of the heart rate is the maximum heart rate where baby can push. It can be 180, 100, 200. With the peak of the heart rate and with the flat CTG, if you go into 1 to 2 hours, that baby is having a cerebral pulse. So that is what it mentioned. So before that, I mean, so we need to decide before that, we need to deliver if the CTG is not reversing. So that is mentioned in the Edwin Chandrana's CTG book, actually.
Thing is, if you are in the reversible stage, even if chemoreceptor decelerations are there, if it hasn't gone to the irreversible stage, like stepladder pattern stage, if you can reverse it, and if you think delivery is not very long, like delivery is within half an hour, 1 hour's time, you can give tocolysis and push it a little bit and see whether it reverses.
Of course.
It's playing with the variable factor, basically. And it's a safe game. If you have any doubt, no, look, it's not going to happen. Best thing is to deliver the baby. You can give some tocolysis, buy some time, plan delivery, even at 9 centimeters. Sometimes some mothers stay 1 or 2 hours. If the delivery is not imminent, yes, you will have to consider delivery. But if you think, look, the way the progression of the labor, is the rapid progression. She's 9 centimeters, head is slow down. Look, just half an hour's time, I can do a quick forceps and deliver the baby. Give some tocolysis, and by that time, if you can, you avoid an unnecessary cesarean.
Okay. And the other thing, Dr. Priyanta, I think, following these 2 webinars, and so I am very much agree with Dr. Buddhika, because he wants to, he suggested the knowledge has to be improved. And, even our college president, Mangala sir, wants to, to find ways for this knowledge dissemination. So
Yeah.
if you try and find a way of, the sort of a formulator, sort of a program or any sort of a plan, so then I think Mangala sir will help us to, to initiate these, whatever the program to disseminate the knowledge
What
and
I
all the categories.
what we talked to, no, we were talking about this. Now I was talking to Asela about this. We can have something, on regular basis, like
Mangala sir, any suggestions? Mangala sir is online. Sir?
Yeah.
we can have a like
Yes.
periodical discussion, like reflection. We can get some cases and discuss. Let people decide. They can bring their own cases. We need to know the ground
Yes.
situation. It's good to discuss cases, challenges clinicians face. Yeah, I can find clinicians from UK. There are so many people who are interested in physiological interpretation. We can have we can fix some time, get people involved, get their opinions, get what people difficulties face at the local level and how they manage. So we can come to that is the way to disseminate knowledge. That is one way. Webinars is another way. We can have workshops, master classes, webinars. We have to have few different ways of getting this message. And we can share some articles. I was telling Asela to create a WhatsApp group. So
Yeah.
get all the clinicians into that. So we can share some articles about physiology, discuss interesting CTGs. Anybody has an interesting case like what Asela had, that acute bradycardia event, we can show those CTGs, we can get the opinion, so we can give our opinion, what we do at this end, so how we can transfer that knowledge. Like that, we can develop that knowledge base because we are connected. In Sri Lanka, we are all connected easily, isn't it?
Yeah.
So we all know. So we can get the advantage of that. So definitely, we can take this to the peripheral level. Ultimately, the maternity care, I'm very much interested. It's very exciting thing, how this intermittent auscultation, because I was never paying any attention to intermittent auscultation. Since this IFS workshop started, then this intermittent auscultation came into, we got to know that. So it is so nice to know that the patients the mothers who are going through this low risk pathway, how you can use intermittent auscultation to pick them up, the problematic ones. Interesting. So there are lots of things we can do. Interesting thing is we have resources. Now, by the look of it, many places are using continuous monitoring. We have resources. We don't have one-to-one care. That's okay. Well, whoever available, we can train them. So definitely, if we make an effort, we can improve the existing system, without spending any extra money or anything like that. Even the existing system, we can improve from what
Even we can make a small poster-like thing, Dr. Priyantha, am I right?
Yeah.
So
Yeah. We'll think about that.
Yeah.
We'll have another chat out of these webinars and see what we can do. Definitely. Thank you.
Yes.
Mangala sir, you want to add something? I think Mangala sir wanted to anyhow do this webinar, and he actually planned this, not me.
It is so interesting to see there are more than 100 people joined today.
Yeah, more than 110. No, actually, Dr. Priyantha, there was more than 110 because this with one port, and there will be like 10 participants.
Right. Okay.
Yeah.
Okay.
So
Right.
maybe like 170, 100, 200.
Oh my God! Really?
Yeah.
Oh, that's
Yeah.
so
More than
interesting.
150, definitely. More than 100.
That's fascinating. So we can continue the same thing, actually, educate people. It is fantastic. Yeah, we are giving our maximum support. I mean, I know Mr. Shankar, my friend who initiated changes in my hospital, he's very happy to join. There are lots of Sri Lankans. Raj Kumar is in London. Lots of us do physiology, so we can take turns and join. We'll find a way. Don't worry. We'll do
That's
it.
a good thing. We can discuss certain CTGs, no?
Yeah.
And,
That's what I realized actually. When we discuss the CTG, it's really critically analyzing the factors.
Yes.
What we should do, what is this, why this baby, what is happening. So they are really go into the deep. And even not only the CTG, we discuss the labor pathway as well. What should have done better. So it's really reflecting the knowledge about the labor actually. So that type of reflection should be there for us to learn. That is what I felt, and maybe we can start a small group discussion like outstation in somewhere with the resource peoples. We can develop that later, but initially we need to develop an interest among our community.
I think the interest is there, no?
That's
By the looking at the participants today, so many numbers. I didn't expect that many numbers to join today. It's fantastic.
Yeah,
So-
the way we are teaching the students and the other pages has to be changed. Like I have learned a lot from this webinar, right? So
Sorry?
the way we teaching the students and the others, right? We have to be changed. There are a lot of things, a lot of new things happening, right? So we are going in a traditional way, teaching the nurses and the doctors. So that's something new to most of us. So thank you very much. So before
No problem.
we wind up, let me again thank the Buddhika and Priyanta for their wonderful presentations.
No worries.
So I think they are trying to have an online platform. I think the Colombo University, they are trying to have an online platform for the CT training. So I think you can yes, definitely you will be able to contribute to them. Richard is instrumental in developing this online platform.
Oh yeah.
So that yes, so that will be very useful.
He has messaged
So-
me. I know he's very much involved into physiology, isn't it? Yeah, we should involve him.
Yes. So
Thank you.
before I end up, let me thank all the speakers and the Sidus Ketila, Sidus Health for providing the platform for the webinar. So thank you very much.
Thank you.
Thank
Thank you.
Yeah,
We'll
thank
see
you.
you tomorrow.
Yeah, thank you.
See you tomorrow.
See you.